Esraa Althobaiti. Good morning, all. I'm Esraa Althobaiti, resident. I'm gonna to present a case presentation regarding the pituitary macroadenoma with the supervision of Dr. Jawad. Really, I appreciate this opportunity, and I want to thank everyone, especially teaching coordinator Dr. Ibrahim and Dr. Jamal for his support in this presentation. Okay, our objectives, I'm going to talk about two case presentations, introduction, anatomy, clinical presentation, investigation, treatment, surgical approach, complication, and adjuvant therapy. Okay, first case, we have here 55-year-old male patient present to the neuro clinic complaining of blurred vision, decreased vision, and headache. There was no history of neurologic symptoms or increased intracranial pressure. By examination, visual field exam showing bitemporal hemianopia, which was worse on the left side. Visual acuity was decreased. Pupil size was normal. Cranial nerve exam was normal. Other CNS exam was normal. CT and MRI done. This is CT scan, axial sagittal view, showing here mass, huge mass, more than 1 centimeter, extending into suprasellar region. And here we have two view of the MRI, T1 MRI. This is a coronal view showing this is mass, more than 1 centimeter, extending in the suprasellar area, compressing the third ventricle and the optic chiasm. And this is other view showing the same finding. Okay, lab done to the patient showing growth hormone was low, testosterone low, TSH and FT low, cortisol was low. So, patient referred to endocrine for the hormonal therapy and diagnosed as non-functioning pituitary macroadenoma. So, patient referred to our department to discuss the option of the surgery. Patient agreed and underwent endoscopic transseptal transsphenoidal hypophysiectomy. Immediately post-op, patient vision deteriorate on the left eye, then improved. As you see here in the perimetry, we have this right eye and this left eye. The right eye is completely resolved or improved, while the left eye here showing still patient have temporal hemianopia or get worse. The headache episode was reduced and there was no CSF leak. Again, post-op MRI repeated again, showing residual tumor about 2 centimeters in size. So patient referred to oncology for adjuvant radiotherapy. Okay, second case here. The second case, just to show you a different presentation. This guy present to the ER with the sudden onset of headache. And as you see here in the first picture, patient can move his eye to the left side, while when he was trying to move his eye to the right side, the right eye is not moving. So that indicates 6th nerve palsy. So MRI done to this patient showing an hemorrhage inside the adenoma, which is called apoplexy. Okay, regarding pituitary adenoma, it's the most common cellular region tumor. It accounts approximately 10 to 15 of all intracranial tumors, classified either according to the size or the function. If the size is more than 1 centimeter, called the macroadenoma. If the size lower than 1 centimeter, called microadenoma. And it's also classified according to the function. If it's secreting hormone, called functioning adenoma, if not secreting hormone called a non-functioning adenoma. Anatomy of the pituitary gland. Pituitary gland is situated here in the sphenoid fossa, has two lobes, anterior lobe, which is secreting a growth hormone, TSH, FSH, LH, ACTH, and prolactin, and posterior lobe, which is secreting antidiuretic hormone and oxytocin. And here is the infundibulum, and here is the optic chiasm. The most important thing in the anatomy is the boundaries. As you see here, this is the pituitary gland. It's bounded inferiorly by sphenoid sinus, and laterally in both sides here we have a cavernous sinus and oculomotor, trochlear nerve, abducens nerve, and the internal carotid. Superiorly here we have the optic chiasm, and as well there is a third ventricle. Posteriorly we have basilar artery. Okay. This is endoscopic anatomic view of the sphenoid. I put this picture to know the approach of the surgery. In the first picture here, we have the sphenoid sinus with the septum. After we remove the septum, as you see here, we have here the internal carotid artery, and there is optic nerve, and there is two rheses here. The rhesus here called medial opticocarotid rhesus, and the other one called lateral opticocarotid rhesus. And here also, in the second picture, is the endoscopic view on the cadaver, showing here. This is the pituitary gland. This is the stalk of the gland. This is the optic chiasm, and this is the optic nerve, optic tract, and this is the internal carotid, and this is the left internal carotid. After we retract the left internal carotid, as you see in this picture, there is an area exposed here called cavernous sinus. And here is the anatomy on the MRI. Here is the sphenoid sinus. This is the pituitary gland. This is the stalk of the gland. This is the optic chiasm. This is the third ventricle, and here we have the internal carotid artery. Okay. Regarding signs and symptoms, most often the patient asymptomatic. The tumor is just found incidentally on the image, but the patient might present with the hormonal imbalance like a hypothyroidism, Cushing syndrome, or hyperprolactinemia, or they might present with the mass effects on the surrounding structure, like in our cases, visual deficit, headache, elevated intracranial pressure, and intracranial hemorrhage. This table explains the symptoms according to the extension of the tumor. So if the tumor is extends superiorly, so that means it will compress the optic chiasm. So patient will come with the visual field defect, either superior temporal quadranopia or bitemporal hemianopia, which is the most common direction of spread. Or if the tumor extends laterally, that means into the cavernous sinus, so the patient usually asymptomatic. But if it extends inferiorly into the sphenoid sinus, usually asymptomatic, but there is a possibility the patient will come with rhinorrhea and meningitis. Okay. Regarding investigation, we need to do a visual field test to know the severity of visual defect, which might indicate that patient needs aggressive treatment. We have to do lab function to know is it the tumor secreting hormone or not, is it functioning or non-functioning. We have to do imaging, either CT scan with the contrast or MRI. CT scan with contrast, as you know, it's better to assess the bone if there is any defect or adhesion. And MRI to assess the tumor itself, to confirm the diagnosis and rule out other differential diagnosis. Okay, here in the first picture, as you see here, this is a T1 MRI coronal view. This is the sphenoid sinus, and this is the pituitary gland. There is an area with hypointense inside the pituitary gland. approximately lower than 1 centimeter. So this is a pituitary macroadenoma. While in the other picture, in the sagittal view here, we have here the pituitary gland, and it's measured approximately more than 1 centimeter. There is an area with hyper intense here. This is T1 with contrast. So this is the macroadenoma, and there is a hemorrhage inside the tumor. And this is another view, coronal view, showing a huge mass extending in the lateral side into the cavernous sinus. Okay. Regarding treatment, we need a multidisciplinary approach. We need endocrine, neuro, ophthalmo, and ENT. Our aim of treatment is to decrease the size of the tumor, to restore the functioning of the gland, to restore the normal vision. Also, we have a medical and surgical treatment. Medical treatment mainly for those functioning adenoma, and surgical treatment is the Ministry of Treatment. We have two approaches, transsphenoidal or transcranial. Nowadays, we use transsphenoidal approach. Regarding transsphenoidal approach, we have either transnasal or sublabial transseptal approach. Transnasal, we have either direct endonasal, that means we will go to the sphenoid sinus directly from the nasal cavity, or transseptal, that means we will do the incision in the nasal septum, then we will do like a septoplasty, we will manipulate the cartilage and disarticulate it until we reach the sphenoid rostrum. Or sublabial transseptal, same like transseptal, but the incision here will done on the sublabial area. Then we will reach the septum, we will do like a septoplasty, then we will reach the sphenoid sinus. Okay, after we reach the sphenoid, the mucosa will strip off, the septum will remove the medial and lateral opticocarotid recess, the carotid artery, the optic nerve, all should be identified. The bone over the sella is fractured. Then after we remove the bone, the dura will be exposed from the one carotid canal to opposite canal, from planum sphenoidal to the clavus. Then after we reach the sella, the dura is opened with the U-shaped incision to expose the fossa. The normal pituitary gland, it will appear yellow and solid, while the tumor will appear amorphous and white. Extracapsular resection will be done, and the tumor will deliver and facilitate by CSF pulsation. The important thing that's to keep arachnoid intact to prevent the CSF leak. So after we remove the tumor, there will be a defect. So regarding reconstruction, the reconstruction will it depends according to the size of the defect. If the defect is small and there is a low CSF leak, so that needs only a graft, either free fat or fasciolata. But if the defect is big, so that means we will need flap like here, a nasoseptal flap. So post-op, patients need close monitoring of endocrine function and electrolyte level, need recurrent visit to the clinic for cleaning the crustacean to prevent infection. Okay. Regarding complication, we have non-endocrine complication of surgery or endocrine complication. Non-endocrine complication like any rhinologic surgery, there is risk of orbital injury, anosmia, cribriform plate injury, CSF bleeding, injury to the carotid artery, sinusitis, meningitis, subarachnoid hemorrhage, tension pneumocephalus, and endocrine complication like a diabetes insipidus, which is the most common complication, and inappropriate releasing of antidiuretic hormone. So the question here, do we need adjuvant treatment? Do we need adjuvant radiotherapy? So they found 20% of the patients, of those with a non-functioning adenoma, they have a residual tumor. And 30% of them, the tumor is increased in size within 5 to 10 years. And it invades other structure. And as you know, the aim of surgery not to remove the whole pituitary gland, it's just for debulking. So that's my explain that. And there is a 60% of the functioning pituitary macroadenoma remain biochemically active after the treatment. So, in summary, that indicates that most of the patients might need a post-operative radiotherapy, like in our case. Thank you. Any questions?
Thank you دكتور إسراء، الله يعطيك العافية يا رب. دكتور جمال، إذا بتحب تعلق أي شيء قبل ما حدا يسأل تفضل.
Still, Assalamu alaikum. And the presentation sometimes comes as acute presentation. They come to ER. Mostly they come with a severe headache, and because they have acute apoplexy, that means bleeding inside the tumor, which causes pressure and causes a severe headache. Just like the slide she showed, Esraa showed the guy with the adjacent nerve paralysis. He presented to ER with headache and 6 nerve palsy. And the other thing, we leave it to the questions. Let's see
Okay, so anybody has any question, please start asking. شكرا جزيلا دكتور إسراء، يعطيك العافية، محاضرة ممتازة.
الله يعافيك.
There are different approaches, of course. As Esraa said, it runs nasal, it runs septal, and the sublabial approach to the sphenoid sinus. I prefer the it runs septal, just like doing a septoplasty, and you reach the rostrum of the sphenoid, you remove it, and then you enter the sphenoid sinuses through their natural ostia, and you increase your opening, and then you remove the septum, intersinus septums, and then you expose the pituitary and the dura. There are some details, operative details, we should know. I mean, whoever wants to do a pituitary should know how to approach the dura, how to deal with the dura, how to open the dura, and how to remove the tumor and staying safe. Remove as much as possible of the tumor, especially the large tumors. And sometimes we use two-stage surgery. In big tumors, we remove as much as possible of the tumor, especially the lower ones. And then we wait for another 4 weeks or 6 weeks, and then do an MRI, and then revisit the surgical site again and remove the rest or more of the tumor. The transseptal approach advantage is that it keeps you in the midline and also helps in the reconstructions, because you will leave the space or the surgical area intact. If you approach it through the transnasal, the sphenoid sinus will be open to the nose. But in the transseptal, the sphenoid sinus is closed again, and it will be drained through its natural ostia again.
Doctor, you open this septum from the anterior part, or you just do a posterior incision and elevate flap?
No, from the start, as doing septoplasty.
Okay.
Mm-hmm. Then you retract you push the cartilage to one side, and then you go to the bone and deal with the bone and remove what's necessary.
If we do a transseptal approach and your septum is mucosa is intact, if the patient develops CSF leak, will it be concealed inside the septum؟ يعني ما بينزل من النوز ولا already بتفتح على النوز كمان؟ ممكن هالشيء يخبي لنا CSF leak؟
Yeah, when you get the CSF leak, you get swollen septum. The CSF will fill the sphenoid and then come to the anterior to the septum as if you're having a septal hematoma. And if you don't have a tear in the sphenoid, in the mucosa of the septum, probably the patient will not feel a CSF leak. So you have to open again and drain and reconstruct.
Why doesn't it drain through the sphenoid ostia?
Because the sphenoid ostia, the sphenoid will be, I usually put fat, and it's filled with tissue, and the mucosa is reflected on the sphenoid. So probably still the openings of the sphenoid, so it will be a mucosal opening actually, because there is no bone. Maybe it didn't form, or the CSF leak is too much that it causes pressure and fills the sphenoid and the septum and septal space. This happens immediately after the operation. Most of the CSF leaks, especially if the patient doesn't follow the instructions of the restrict exercise and activities, social activities.
يعطيك العافية دكتور جمال. بدي أسألك if you will access through transseptal, you can do it by two-handed surgeon, one to hold the camera and to hold the instrument by two hands, or how's the access? Because if you open transnasal, you have two-handed surgeon, one for camera and two for instrument. Maybe the exposure better. I don't know. I haven't seen it with transseptal. Usually, I think transseptal also they use it. Open transseptal and use it by the microscope. For the neurosurgeon, do it, not by endoscope also.
Well, usually the neurosurgeons they do the sublabial incision. And sublabial, and they use the microscope. And the transseptal, one of the disadvantages of the transseptal is the limited space for manipulation. Yes, you can do forehand surgery, someone will hold for you the camera, and but it is not like if you do it transnasal. Transnasal, there is much more space for manipulation. For each approach, there is advantage and disadvantage, of course.
Okay, thank you. After the surgery, you fill the sphenoid sinus with the fat, or the sphenoid sinus with fat?
Yeah, especially if I have a CSF leak or the defect is large. My concern is to support the graft and the reconstruction I do post-surgery to close the pituitary opening.
And regarding the...
not necessarily to fill it, not necessarily to fill it with fat. You can fill it with gel foam, Surgisil, whatever.
But you feel, and the nasal packs, you use them after surgery to make compression on the nasal septum?
We use the patch to compress it and also to hold the mucosa, sinus mucosa in place. And we do a lot. We also, there is the CSF leak and high pressure CSF leak. We put lumbar drain to relieve the pressure on our reconstruction. Did Esraa mention that?
According to your experience, vision loss, is it reversible or irreversible?
It is reversible most of the time if you do it early. And I had a few cases with a visual problem, visual field problem, and they improved, or not improved, it's become normal after that, after the surgery. For this case, if you remember, some of you followed the patient post-operatively, he had a deterioration post-operatively, immediate post-op, he had deterioration in his visual field, but later on, he had improvement in the visual field after a few days. Also, he had a severe headache post-surgery, and then it was relieved.
Dr. Jamal, for asymptomatic macroadenoma, do you think the patient, as incidental finding, does he need for further investigations, for completely asymptomatic, just incidental and imaging? Does he need further management or something, or just follow up?
Yeah, he needs hormonal assays, and it depends on if the tumor is pressing. We have to. If he's asymptomatic hormonally and size-wise, it's not pressing on structures, vital structures, then probably a follow-up MRI would be recommended. Some of the tumor, extensive tumors, the endocrinologists, they sometimes treat them medically, and it regresses actually and relieve the symptoms, especially if the patient is not fit for surgery. And regarding sometimes we use as a primary modality or as the secondary modality post-operative, the radiation. We use the gamma knife. I mean, this is also effective actually. Sometimes the radiotherapy is the primary modality of treatment.
Okay, thank you very much, Dr. Jamal, for the explanation. We have another 5 minutes if anybody has any question. Otherwise, we'd like to thank Dr. Jamal and Dr. Esraa for this great presentation and informative lecture.